Hi, this is Jennifer Coluciello, and this week we're going to talk about an emergency scenario that was presented as well as mental illness. In the case study that was given, a short history of a 54-year-old female, differential diagnosis would include several items, the primary being alcohol abuse. Another option is methamphetamine use, which we would be able to rule out relatively easy with a gross assessment of her pupils on scene. If they were dilated, that's a possible. As in medicine with every patient, especially with altered mental status, we must always consider that the AMS may be caused by some underlying physiological issue, not just substance abuse. And so, there are many other things here that could be at play, head injury, dehydration being two of those. But in medicine, we also have a saying that when we hear hoofbeats, we think of horses, not zebras. And so for the purposes of this discussion, I'm going to focus on my primary diagnosis of alcohol abuse, which is really the most likely one in this patient. It's important to understand that there are short-term effects when there's alcohol abuse and misuse on board. These include impaired coordination, slurred speech, unsteady gait, problems with thinking clearly, memory, and even dehydration. These can lead to other items that are happening at the time of the crisis, such as falls and injuries, which were evidenced in the case presented, as well as alcohol poisoning, high-risk behavior, and even violence and aggressive tendencies. Long-term risks are going to include a myriad of cardiac and liver diseases, hypertension, stroke, heart disease itself, peripheral artery disease. The immune system can be compromised. Liver disease such as cirrhosis can occur, liver cancer, and even other cancers such as mouth and esophagus and larynx. These concurrently can also have some impact and development for anxiety and depression, as well as problems with the family and in the workplace, other social issues, and all of these can combine to create suicidal ideations in the patient. As with all items in medicine, it's important to understand a little bit of what the physiology is involved, even if you're not dealing with a long-term assessment, evaluation, and management of the patient. A couple key things here are the aggressive tendencies of patients with alcohol abuse. As that alcohol level increases, it's actually going to interfere with the function for cognitive control in the brain. This is actually going to cause the patient to have a decreased ability to read the situation, the verbal language, the nonverbal language, the verbal intonations, the interactions, and all of the context that's happening around them. This narrowed understanding is going to cause them to act out, may trigger them, and may cause actual aggressive responses in the patient. In any of these patients, while yes, we're dealing with the acute issue, we must understand and try to determine if there's a history of chronic heavy drinking. If there is, there may be another issue at play, such as the thiamine deficiency that could develop, which will actually lead to memory and learning disorders, confusion, and memory loss. If this person that we're dealing with, such as in this case of this female, has a history of heavy drinking, there could be this thiamine deficiency causing confusion and problems with memory. Add that to the current issue of interfered and impaired cognitive control, and those aggressive responses can even be more heightened. Another thing to consider is that as the patient is actually lowering those alcohol levels and that is being flushed out of the system, it's going to flood the brain and the nervous system with activity that, while they were intoxicated, was not there. This hyperactivity is actually going to result in tremors and shaking in the extremities. This could be anywhere from mild to severe, and in some cases is so severe that it actually impairs upon activities of daily living. Some assessments that we're going to be need for this patient are vital signs recurrently. We'll also get a urinalysis, probably do a CT scan to rule out head injury or any bleeding in the head there. Probably not an MRI, but the healthcare system may choose to do that if they need a more detailed anatomic view. Lab testing is a must for this patient for the glucose level, drug screens, basic chemistries, electrolytes, and thyroid function. As in all medical emergencies, there are going to be 3 stages of treatment. The first will be an acute, and that will be to identify and treat any urgent life-threatening issues. The second will be stabilization. Basically, we're going to implement treatment to get control of those issues. And then the third will be maintenance. This could be inpatient, often transitions to outpatient, but this is where we look to keep the control that was gained over the issues and determine what recurrent review and adjustments need to be needed. So this is ongoing control. These treatments for especially mental illness or substance abuse will actually combine 4 different items. There will be the physical health concerns, obviously for current health, and then protection of future health. But there will also be work done on the emotional health side to try to recognize, understand, and work through any underlying issues that may be contributing to the mental health issue. Once those items have been identified, there will be work done on the mitigation side, looking for ways to help the patient deal with these underlying issues. Some could be medicinal, some could be behavioral, lifestyle changes, and also how to navigate their triggers, since certain things just cannot be avoided. The fourth aspect here is actually really, really important, and it's education and guidance for the support system, the family and friends for this patient. Not only on how to actually just understand what's happening and deal with it themselves, but also on how to help the patient and set them up for success. When it comes to mental illness, there have actually been a few key steps taken. The first of those was the Mental Health Parity Act of '96. It was a great step forward, started mandating this at no additional cost for large group employers, but it didn't address a few subjects. Subsequently, in 2008, the Mental Health Parity and Addiction Equity Act actually reaffirmed the MHPA, and it expanded this to include SUDs. It also prohibited increased cost sharing from general health benefits, and it also made sure that there were no treatment visit limits and network limitations. It addressed those issues that had not been addressed by the MHPA. After that, we've got the Affordable Care Act in 2010. This actually expanded to mandate health coverage for behavioral items for all employers. It also expanded the list of essential health benefits to include mental health and substance use disorder. And it expanded this mandate not just for federal marketplace plans, but to the individual health insurance market. While these are great steps, there probably is still room for improvement in 3 different areas. One, we need to enforce those laws that have been set in place and make sure that that equity is there and the availability is there. The second item is education. We need to increase the education of everyone, healthcare personnel, employers, individuals themselves. We need to increase education and reduce the stigma that is with this. Many of these items are hereditary predispositions, and it is not always just a lifestyle choice that somebody decided to pick up one day. We also need to increase the access. These items are costly and sometimes just not readily available, and that's an area where there's definite improvement possibility. And I've listed here several resources as well, and references that I've used to gain this information, and this has been very, very informative. Thank you.